Good afternoon. Welcome to our second webinar with Thermo Fisher Scientific. My name is Lisa Rascon. I'm with the Arizona Asthma Coalition and the University of Arizona Pediatric Pulmonary Center. Today's topic is pet allergies and the relationship with asthma. Facilitating today's webinar is Jean Nelson. Jean Nelson is a nurse practitioner and has been working with allergy, asthma, and immunology for over 30 years. She's also a very active Arizona Asthma Coalition board member and has been since 2013. We will be recording this webinar and we'll answer the questions at the end. Please use the chat feature to ask your questions and we will go through them after the presentation. Please make sure you are on mute to avoid any disruptions. Jean, take it away.
Okay, thank you, Lisa. I'm excited to be here today. I want to start by saying that because I think this is such a great topic and certainly pertinent to so many. And this is really my life. As you look at my bio here, you can see I graduated from ASU both with my bachelor's as well as my master's in science and nursing and with my nurse practitioner certification. And I landed at allergy, asthma, and immunology in 1984, a long time ago. I first started as a nurse, worked here as 17 years as a nurse, and then went back to school, decided to be a nurse practitioner, and now I'm very proud to be one of the partners in the practice. And as Lisa said, I've been a board member for quite some time, and you see my credentials there at the bottom. So let's move on to the next slide, which I think is going to talk a little bit about our objectives. This is our roadmap for today, guys. We're going to look at the need for the whole team as we look at folks with asthma. And, it really does take a village. And I think that's so true in medicine. We're going to look at testing. You wouldn't think about not being tested if you thought you had high blood pressure or high cholesterol, that sort of things. So we're going to talk today about how testing is important with allergies as well as with asthma. We're going to look at ways that we can be very intentional with our environment so that we can kind of target some of those things that we are allergic to and reduce our exposure. And then we're going to look at a patient case. Next slide. Okay, so this is a great picture of Gabriel Ortiz. I'm going to turn it over to Gabe to tell us a little bit about himself.
Thank you, Jean. Appreciate that. And thank you to the Arizona Asthma Coalition for inviting us to partner with them again on the second of our webinars. As you can see from my bio, I have been fairly active in asthma care. I've been a PA for over 30 years, 28 of which I've spent mostly in the pediatric pulmonary practice doing allergy, food allergy, served on the NIH and on the NIAID for the peanut prevention guidelines. So very active in most things, allergy, mostly asthma, which is my passion, especially for pediatric asthma. So we'll get into that, the relationship of pet allergy as we talk about asthma. So I like to start with a good foundation. What we talk about the atopic march or the allergic march, those seemingly unrelated allergic diseases, as we look at them over time. We see that atopic dermatitis and or general catchphrase they say is eczema. But in allergy, we like to specifically talk about atopic dermatitis. We tend to see that fairly early on at about age 3, before age 3. So we appreciate those allergic children by their atopic dermatitis, whether on their face or the flexural areas, and going along with food allergy. So much of that food allergy is diagnosed early on in life and tends to decrease later in life, as you appreciate from this purple line. But inversely, you see a drastic rise of allergic rhinitis, appreciated here as rhinitis, after which time this the 3-year-olds generally have had 2 seasons of those seasonal allergens, the grasses, weeds, and trees. And if they're atopic, they certainly begin to manifest those symptoms: itchy, watery eyes, runny nose, maybe coughing and wheezing. And you also see an increase in that asthma. So this is really what we like to talk about, what we like to identify those allergic triggers. You see represented here in a little bit different format, in a circular type of formation, those atopic diseases that we looked at, those allergic diseases beginning with that eczema or atopic dermatitis. More specifically, in allergy, we like to look at those rashes that are allergic in nature, those GI distresses. And certainly we need to differentiate when we look at GI distress, whether it's true food allergy or intolerance, or maybe a combination of both, maybe some food preferences, allergic otitis media, allergic rhinitis, and allergic asthma. So you can see those that have more severe risk of asthma are those that have both inhalant allergies and food allergy. So it makes it quite important to be able to identify those allergic triggers to give our patients a better quality of life and certainly reduce symptoms. So what we want to do is certainly identify those allergic symptoms, those allergic triggers, to minimize symptoms, keeping in mind that there is a strong correlation with the upper airway and the lower airway, what we call the united airway. Jean, let me ask you, how do you share this information with your patients?
Well, I have to say, I do it kind of simply. Is oftentimes I'll say to my patients, we're one big tube. And I know that's very simplified, but you know, you start at the tip of your nose that goes to the base of your lungs. And I always say to my patient, there's no trap door in there. There's nothing that slams shut. So if you've got inflammation in your nose, there's this trickle down effect that ultimately can lead to asthma. So we know that there's this huge overlap, which is so well shown here. And we know that you already suggested that if you have a child that has allergies, there's a greater chance that they're going to develop asthma. And we know that 80% of people with asthma also have allergies. So these two really do go hand in hand. And I try to always stress that to my patients, Gabe.
Good point. Yeah, I like to say we need to treat the sneeze to control the wheeze, because we can always give them antihistamines or intranasal steroids, but they may also have some kind of inflammation going on in the lower airway. So I think an important point to be able to relate to our patients and have them understand that even upper airway irritations and or triggers can cause lower airway hyperreactivity, especially when we're looking at those inflammatory triggers. We want to understand that up to 90% of children and 60% of adults that have asthma have an allergic trigger. So I often say many providers understand allergy and asthma. I think it's best that we think about it as allergic asthma, and that way we can be able to identify maybe some of those allergic triggers. Also keeping in mind that there may be some non-allergic triggers, maybe several non-allergic triggers, many of which I like to talk about: cigarette smoke, strong odors, perfumes. So sometimes those non-allergic triggers can often cause a lower airway inflammation and irritation. So some of those problems that we need to look at as well, and maybe some of those in our assessment of our patients, identify those allergic and non-allergic triggers. Knowing that there's only two ways to identify those allergic triggers: by sensitization, understanding that those test results, whether it be in vitro blood test or skin testing, is sensitization and may or may not be true clinical allergy. So the test results should be correlated with certainly an assessment of the patient, clinical symptoms, clinical reactions, and then correlating that with those test results. So certainly goes a long way to be able to identify those allergic triggers, and certainly being able to minimize exposure. When we look at asthma, certainly there's a big economic burden and cost that is related to asthma, especially these days. We see numbers increasing. Many of our patients with asthma tend to use the emergency room as a revolving clinic. They may have an exacerbation, go to the emergency room, incur significant expense. We're looking at indirect and direct costs. Maybe a child missing school means a parent may miss work. So those indirect costs, and many times when those patients are seen in the emergency room, they're given costly medications. So as per the national guidelines, they recommend regular follow-up visits and maintain good control. If you can need additional referral, maybe a referral to a specialist to help manage maybe additional comorbid conditions and maybe additional medications and or treatments that can be done in the specialty office. Knowing that about 75%, over 75% of those patients with asthma are managed in the primary care office. We certainly commend primary care providers for managing these patients with asthma. But again, remember that there are some specialists that may do additional medications, maybe additional treatments that could be warranted for these patients that use a lot of the medical utilization. This here representing the National Asthma Education Prevention Program Expert Panel 3 report, Guidelines for the Diagnosis and Management of Asthma. We see 4 core components which are of great value within the document. One of them that we like to think about is control of environmental triggers. I often say that it's nearly impossible to control those environmental triggers if you don't know what you're trying to control. So I like to add to this, identification and control of environmental triggers goes a long way. Jean, how do you share this information with your patients?
Okay, so I always tell my patients, first of all, after we complete testing, as we look at allergies, there's 3 things you can do about allergies. There's avoidance, there's medications, there's allergy injections. And I think as a healthcare provider, we do a great job of kind of assessing and monitoring and then, suggesting pharmacological treatments. I think sometimes where we fail with this slide is the control of the environmental triggers. Are we talking to our patients? Do they have pets in their home? Is there mold? Is there dust mite? When was your house built? Has there been any leaks? That sort of thing. And then education. Education way on the right there, I think is largely ignored, unfortunately, and perhaps might be the most important part. But it takes time, Gabe. And, as a healthcare provider, I can tell you I have 15 or 20 minutes that I spend with my patients, right? And then, by the time you do those other things, sometimes you kind of run out of time. So I think we have these guidelines that we need to follow. And I think as a provider, we need to do a better job with controlling those triggers and in education. Both of them deserve more attention, and primary care especially, I think, really needs to focus on this more heavily.
Good point, Jean. I like the comment you mentioned about generally most of us as providers have a 15-minute appointment. That means going over their assessment, their history, certainly doing the physical exam, certainly doing the plan, and education many times may get left to the end or maybe even ignored. So being able to follow patients on a regular basis, maybe being able to do a little bit at a time and asking them how they're doing with that can certainly go a long way. But it is true. I think they may need a little bit more than what is regularly scheduled as that 15-minute appointment, or maybe even more frequent appointments to assess how they're doing and continue to go over that not only control of environmental triggers, but also, as you mentioned, pharmacologic therapy, right? Many times patients may get confused about their inhalers, right? Certainly inhaler technique is another big thing that needs quite a bit of education.
Yeah, I couldn't agree with you more. I think sometimes we throw inhalers at our patients and say, okay, this is your rescue, and this one you use twice a day, and this pill you take, and I think sometimes people have kind of a dazed look as they leave our office. So I couldn't agree with that more.
Exactly. And especially now if someone is persistent, right? Persistent asthma, as we see here, maybe they're using a low dose inhaled steroid and they think, well, that's 2 inhalers, right? So education on those 2 different inhalers, what they're for, quick reliever, right? And controller, and not to get them confused. So this is one of the major tables out of that NIH asthma guidelines publication. We see the classification difference of intermittent asthma and persistent asthma. So intermittent asthma are those patients that use PRN albuterol only, and everything else is persistent. Persistent asthma is divided into mild, moderate, and severe, dependent upon level of care and spirometry. Within that recommendation, within that guidelines, they recommend patient education and environmental control at each step. All of these patients with asthma may have intermittent exposures. Even those patients with intermittent asthma may have occasional exposures. And I always like to talk about the cat, knowing how much dis-ease cat causes my patients. I like to mention cat. When we talk about those patients with persistent asthma, recommended within those guidelines, again, are testing, at least for those patients with persistent asthma. And that is the best category of evidence that we have. That is category A evidence within the 2007 document. So certainly being able to relate this to our patients goes a long way, because as we know that most allergic pet owners will not get rid of the household pet. So it's really important for us to be able to explain to them what we need to do to be able to help them with that. In talking about household pets, this number here not only is important to understand that 90% of homes may have at least 3 triggers, but some of you may have heard that during COVID, rescue adoption has gone up 90%. So that just means more pets in the home. So is that what you're finding, Jean? How do you, have you found that your patients have more pet allergies, and is it becoming important in your practice?
Yeah, absolutely. Absolutely, Gabe. And I think, when we think back on the last few years, think about how much time we've been spending in our homes, right? There's COVID, there's quarantine. So many people are working from home. Some folks are homeschooling their children. I know even for myself personally, even though, hopefully we're approaching the end of the pandemic, I'm still not at that place where I go to movies as much as I was, and, out on Sundays and Saturdays and the week, those kind of things. And so just innately, we're spending more time at our home. And look at this list here. You might have a pet, you might have some molds, and you might have some dust mite. And I think, who knows what you're allergic to? Sometimes I have patients that come to my office and they are complaining. I do their allergy testing, allergic to nothing. Last week, I saw someone that came, was 100% sure that she was allergic to cat, and that wasn't it at all. She was allergic to a lot of other things, and vice versa there. So I think looking in our home and also outside of our home, we're approaching the fall months now. I'm here in Phoenix. And so as it gets a little cooler here, we're spending more time outdoors as well. So you have to kind of couple those things together. We've got those indoor allergens, and now we're going to be starting the fall season. And of course, then you also have to superimpose more infections in the fall, kids going back to school, more exposure. So it really becomes the perfect storm.
Exactly right. Yeah, and when we talk about, I think most of us would hope that we're over COVID, right? But still, maybe not yet. We hear that certain cities are maybe going back to mandating mask mandates and things like this. But when we initially started, right, in the pandemic, we were talking about shelter in home, shelter in place, and possibly having many of our patients with asthma maybe have more exposure to those indoor allergens. So exactly what Jean is talking about, not only those indoor allergens, but now many parts of the country also having those seasonal allergen exposures as well. But when we talk about pets specifically, we know that shared with you, not only has rescue adoption gone up, we see millions of Americans that can be sensitized to both cat and dog. And we see that many of them may have multiple pet extract sensitization. And we'll talk about that, especially when we talk about the components. So showing you those pet components which are available, you'll see the 4 for cat across the top, the 6 for dog, and the 1 for horse. Keeping in mind, seeing that those bars, the serum albumin cross-reactivities, we see that the FeLD2 of cat cross-reacts with the CANF3 of dog, and the lipocalin cross-reactivities, the FeLD4 of cat cross-reacts with the CANF6 of dog, and the EQC1 of horse. Well, when I first heard this information, I thought, well, that's very interesting, because I have patients that have significant exposure when they ride horse, and it could also be other things, right? When they're out there in the horse pens, it could be, the hay, the dirt, and maybe some non-allergic irritants, maybe some mold in the hay and things like that. So being able to give them the specific cause of their symptoms can go a long way. We also see additional lipocalin cross-reactivities with the FeLD7 of cat and the CANF1 of dog. So being able to identify the specific species that is causing the problem can certainly help, especially when there's a lot of questions about pets in the home for our patients that have asthma. We see quite a bit of really good information here showing us that as those PET components increase, positive PET components increase, we see that there's future risk for additional allergic diseases. Well, we know that pretty much in allergy. If we find someone that's atopic or allergic, we try to minimize exposure to those things that they're allergic. But this is a really good 12-year follow-up that actually gives us increased risk of future allergy. So testing at an early age can give us quite a bit of really good information as to exposure, pet exposure, and pet avoidance, especially when we look at many of those, many families having quite a bit of pets. Also, the component for dog, this CANF5, is an androgen-regulated protein expressed in the prostate of male dogs. So we have information showing us that up to 30% of dog allergic patients that are monosensitized may be able to tolerate a female dog or a castrated male dog, showing that after castration, that androgenic protein would decrease. So really good information, especially when you have patients come in and ask you, I'm considering getting a dog, not which kind of dog, but maybe which gender of dog may be beneficial. So to help us express that a little bit better, this case report of a 35-year-old male with asthma since childhood. So we know he has asthma. He's developed some rhinitis symptoms at work and his girlfriend's house. He has mild persistent asthma, and he's already on a low-dose inhaled corticosteroid. But he works as a teacher, and again, remember, he's symptomatic in the classroom without a cat. So as been reported, cat dander has been found in classrooms without cats, in shopping malls, supermarkets, carried in by our cat lover people. And his girlfriend has a cat, so he has that exposure, and he's considering a dog. So some additional testing may be warranted and certainly appreciated. On his physical exam, we see that he has that mild rhinorrhea, some mild rhinitis, and mucus secretions. So we want to ask, what additional information would be beneficial? What would be good to help us manage this patient's case as we move forward? So they decided to test him. His in vitro test results show that cat at the top of the list, also dog. He also has additional sensitizations to a dust mite and mold. So understanding what his allergies are, we can understand and appreciate that he is allergic phenotype of asthma. He has additional allergies as well. So several questions that arise. We know he's sensitized to cat, dog, dust mite, and mold. We think about giving him additional recommendations and maybe some treatment and management, how we want to proceed with this case. As they appreciated, they got his PET component test results, showing you those with the PET components overlapped here. We see that his FeLD1 is species specific and the primary sensitization for cat. FeLD1 being the major protein in cat, that is more than likely causing his symptoms. We do understand from his case, he's symptomatic in the classroom, and he is getting exposed not only at his girlfriend's, but maybe also from some of his students bringing in a cat allergen to the classroom. The FeLD4 is cross-reactive with a CANF6 and the EQC1, one of the lipocalin cross-reactive proteins. The CANF1, also a lipocalin, and that's cross-reactive with the FeLD7 of cat. The CANF2 is a lipocalin, but it is species-specific for dog and not as high level as the FeLD1, but it is, again, species-specific and allows for him to have co-sensitization to both cat and dog. So several questions that arise. Is it allergy? We can answer that. Certainly, we need to give him additional recommendations as far as his allergen exposure reduction. certainly you can think about quite a few things in this case and whether or not immunotherapy would be warranted for him. So certainly in review of his case, we see that he's diagnosed with both allergy to cat and dog. Again, remember, he's considering a dog. He also had greater than 3 pet components that were positive, and therefore he's at increased risk of more severe asthma. So some additional management considerations that we need to give to him. Certainly some target exposure reduction. We need to talk to him about the cat, his exposures as well, the dust mite and the molds. Certainly probably better off as we look at his additional treatment. We would have him continue on his daily inhaled corticosteroid and more than likely have a daily inhaled intranasal steroid, which is recommended, and maybe a PRN and a histamine if he has a continued cat exposure, especially at his girlfriend's house. So again, several questions, right? Is he going to keep the girlfriend? Is the girlfriend going to keep the cat? Will she make a consideration as to his exposure with the cat? Seeing as how he has the FeLD1 is the primary allergen component, he would be a good candidate for cat immunotherapy, and maybe at that time they would be able to add the dust mite and molds as well. Give him a little bit more treatment if he decides to do that cat immunotherapy, which would be highly recommended, especially given the fact that he's being exposed and he is already symptomatic in the classroom. So some good management information that we have there, and I'll turn it over to Jean to complete the webinar.
Okay, so go ahead and move forward with this. I would refer to this slide as the cup that runs over, quite frankly, because you can see on the bottom there, you've got your dust mite, your mold, your irritants, and then we've got spring and fall. And when spring and fall come, we've got the birch pollen there. It shows between May and June, and then we get sick in the fall months, and then right around the holiday time again. And so you can see kind of the tip of the iceberg there that's above the symptom threshold. What does that mean? It means that that's when the cup runs over. Then we've got, the increase in nasal symptoms. Again, we've got the increase in asthma. So as we look at the next slide, you're going to see that there's a difference here that, look at that. We're under the symptom threshold. And all that's really changed here is that we've done more environmental control. We've taken care of the dust mite, perhaps just a little bit less mold exposure. We've become more aware of our environment. So all of those things are still happening. Spring and summer still happens. Birch still pollinates, and we still got those times of the year when we get viral infections. But lo and behold, we're right underneath that yellow line, which means, yeah, we've got some symptoms, but not the same severity. So this is really useful information and something that we need to remember. We need to not overflow that cup and be careful with our environment. Let's go on to the next slide, Gabe, which I think is kind of closing us out here, is that we have to make sure that we're reminding our patients, when you have asthma, you may have daily symptoms. I think sometimes what people forget is they think when they're having a good day, they don't have asthma anymore, or they have good weeks or good months. So then they stop their inhalers, right? Don't we see that all the time? I didn't think I needed my Symbicort anymore. But most patients do have those daily symptoms, and it's a costly disease. I think you did a great job of exemplifying that. And I want to stress one of the things you said that I liked is, think about with kids how much missed work that you have as an adult, right? Because your child has to stay home. Mom or dad has to stay home with them, right? So there really is a strong economic burden. But now we've got these specific IgE test results, which was really a mouthful for Gabe there. I think, there was a lot of information there, but look how specific we can get. So then we can control the environment. We can reduce those triggers to reduce the symptoms as well as the costs. So there really are some great guidelines that says we need to do allergy testing for all of our asthmatics. Some people know they're allergic and others don't. They just plain don't know. And as we saw with the case study, is it a dog? Is it the cat? Is it the horse? Is it a combination of all of those? And just like the teacher, he had exposure in the classroom, girlfriend, and so forth. Let's move forward. Okay, so I think there we go. That's the end. I think we're looking for any questions that we might have.
We have one question in the chat. It's, how do you educate patients about preventative measures?
Jean, you want to take that? I think you spoke to that already.
Right, yeah. So I, once I complete testing, the next place I go is, what can we do about your allergies? And so again, I start with, there's three things. There's avoidance, there's medications, and immunotherapy or allergy injections. But then I get very specific about, you need to keep your doors and windows closed, right? Run your air conditioner, helps to filter the air. Don't sleep with that bedroom window open. I encourage my patients to take a quick shower at the end of the day, because recognize that through the day we capture pollen on our hair, on our skin, and on our clothes. So making sure we rinse that off at the end of the day. Making sure you're changing that bedding regularly, right? Because anything that's on your hair is now on your pillowcase. And even if you're not allergic to your pet, think about those dogs. I call dogs, and sometimes cats as well, little pollen traps, right? Because the dogs go out, then they come back in. And what do they bring with them? They bring pollens, the grass, the trees, the weeds, and so forth. So those are the biggest things that I point out to my patients. Now, if they're allergic to mold, again, we have to watch in our shower for those sort of things. Dust mite, where does dust mite live? It lives in your pillowcase. We should be getting a new pillow like once a year. People think, just because it's dusty outside, that's not what you're allergic to. You're allergic to the actual dust mite. So again, as we said earlier, there's a lot of education that can be done here, and that certainly includes these preventative measures.
Good point. Yeah, I would just reiterate a couple of points that you made. Actually, having our patients recognize that as they're outside during the pollen season, they do accumulate that on their hair. And simple things, shower off before going to bed at night. I often say that, they're sleeping in their pillow, breathing in all of those pollens all the time. I also like what you talk about. I talk about those indoor-outdoor pets, right? Bringing in the outdoor environment again, maybe getting in the bedroom, getting on the bed, and certainly we don't want them sleeping with any more enemy if they have allergy to the outdoor environment, grasses, weeds, and trees. But another thing is really important, I think you hit on this, Jean, was actually having them recognize that mold could be, maybe in the shower or under the sink. They may have a drip that they may not have seen. In fact, I found a drip in one of my sinks the other day and had to clean that up and try to minimize that drip and repair that. So even hidden, those allergens and or triggers may be around in places that you wouldn't think to look at. So just another thing I think you may have hit on is maybe if someone has had a leaky faucet, maybe wetting the carpeting. The carpeting should be pulled up because the padding may be getting moldy and exposed. So all of that maybe need to look at.
Mm-hmm. Yeah, one other thing as you relate to mold, I think a lot of people don't realize that you can find mold in your houseplants, in the soil if you've got a houseplant that you've had around for years and years, and maybe you have 7 of those houseplants. You can have mold that grows in that soil and in the underneath side of leaves. People don't think about that. So I always tell my patients, unless you're real connected to your houseplants, and if you have a mold allergy, let's just eliminate that risk. And of course, we have mold exposure just outdoors as well. Mold sporulates every day of the year, just kind of shoots off their damp compost piles, grows on the, the side of trees, again, underneath leaves. So we've got some things we can control and others we can't. So we have to do our best.
Right. Yeah, and if those of you online wouldn't mind taking this quick survey, if you want to text this code to this phone number, it's a quick anonymous survey. We use it to get information about these webinars, and it allows us to plan for the future. With that, I'll stop sharing after this so that we can see Lisa. I don't know, Lisa, if you have any.
Yes, there's one more question. Are you aware of any studies available related to the effect of the building materials, off-gassing furniture, paint, and finishes found in the homes?
So I'll start with this, and Gabe, you might fill in, and I'm not sure that I understand the question, but I think what I hear is that would be somewhat of an irritant, like perhaps the smell of new carpet, if you will, the smell of new paint. So sometimes people, we have referred to earlier, you know, there's cigarette smoke, there's any kind of irritants, particulates in the air, and I think sometimes when you're in a home like that, there can be odors that can be very irritating, that can cause very similar inflammatory response, just as allergies do. Do you agree with that, Gabe?
I agree, Jean. Yeah, good point. Certainly that those new constructions, the paint odors, volatile organic compounds, those strong and new paints can cause, as you say, non-allergic triggers and irritation in the upper airway. I do understand in new carpeting, it's actually formaldehyde, the scent that is there that can cause quite a bit, and it tends to be quite a pretty strong odor for some people, maybe causing some irritation, sneezing, and additional irritation as well.
Perfect. Do we have any other questions? Well, we want to thank everyone for joining us today. This is recorded and it will be on the Arizona Asthma Coalition site. We thank you, and if you have any additional questions, be sure to put them in the chat, and if we don't get to them, we will email you with any responses. Thank you all.
Thank you.
Goodbye.
Goodbye. Have a great day, everyone.